Hello everyone, I'm Olivia from Geeky Medics. Today I'm going to take you through how to interpret a chest x-ray. If you haven't already, make sure you subscribe to the Geeky Medics YouTube channel so you can be the first to know about our latest videos. In this video, I'll take you through a structured approach to interpreting any chest x-ray. At the end of the video, there are several cases for you to put these skills into practice and test your understanding. Remember, when interpreting any chest x-ray, the clinical context is key to effective x-ray interpretation. Let's start by discussing the basic principles behind obtaining an x-ray. An x-ray uses high-energy electromagnetic radiation composed of photons to create two-dimensional images of three-dimensional structures. Structures that are less dense are penetrated more easily by the photons and appear dark or black on film. An example of a structure that has a low density are the lungs. In contrast, denser structures are much less easily penetrated and appear as a white colour on film. Examples of these structures include bones and dense tumours, such as metastases. Some structures, for example soft tissues, only allow some of the photons to pass through and will normally appear as shades of grey. Before interpreting a chest x-ray, you should check the following details. Firstly, confirm the name, date of birth and hospital number of the patient and check this matches the details on the x-ray. Check the date and time the x-ray was performed. And finally, check for any previous imaging, as this is useful for comparison. As previously mentioned, it's important to understand the clinical context as to why the chest x-ray is being performed. For example, does the patient have any symptoms, such as shortness of breath or a cough? Knowing these details will assist with your overall interpretation and differential diagnosis. The first step in our approach to interpreting a chest x-ray is to assess the quality of the image. Poor image quality can obscure important film findings, and so ensuring the image quality is appropriate is essential. A useful mnemonic to assist with this is RIPE. This mnemonic corresponds to R for rotation, I for inspiration, P for projection, and E for exposure. Let's look at how to assess each of these in more detail. If the patient is rotated, it can become very difficult to appreciate any abnormal anatomy or pathology. When the patient is correctly positioned, the vertebral bodies and spinous processes will be vertically aligned. You must also assess the medial aspect of each clavicle, which should be equidistant from the spinous processes. When capturing an X-ray image, patients are asked to inspire and hold their breath whilst the film is taken to ensure appropriate and accurate anatomical features are visualised. To assess whether there was appropriate inspiration, the following structures should be visualised. Firstly, you should be able to identify at least 5 to 6 anterior ribs, which can be distinguished from the posterior ribs as they appear to slope downwards. Next, ensure you can visualise both lung apices, both costophrenic angles, and the lateral rib edges. The standard X-ray is usually a posterior-anterior projection. This refers to the X-ray beams passing posteriorly through the patient before reaching the detector. This contrasts with anterior-posterior films, where the X-ray beam is passed anteriorly through the patient. An AP projection is often preferred when the patient is very unwell and unable to tolerate being mobilised. Look out for a mobile label on a film, as this is likely to indicate an AP film. Alternatively, any plain film which does not mention AP, assume this was performed in a PA projection. PA projection is the standard as this allows for the most accurate assessment of the cardiac size and produces the highest quality image. In contrast, an AP film often gives a lower quality image. Avoid drawing any conclusions about the heart size when using an AP film, as the heart size will appear exaggerated. To summarise some factors to look for to distinguish a PA versus an AP film, the first is the heart size. As aforementioned, the cardiac size is usually exaggerated in an AP film. Additionally, if a patient has not been asked to cross their arms over their chest when taking the film, the edges of the scapula are often visible within the lung fields of an AP film. Finally, E stands for exposure. It's important for a film to be correctly exposed to allow for visualization of the pulmonary vessels, lung fields, and bony anatomy. Overexposed films appear darker. Whilst the bones and heart are easy to appreciate in an overexposed film, the lungs and pulmonary vessels are difficult to visualize. Underexposed films appear more white and make visualization of the retrocardiac region and spinal anatomy difficult. As a general rule, To check for appropriate exposure, the left hemidiaphragm should be visible to the spine and the vertebrae should be visible behind the heart. Now it's time to systematically interpret the imaging and identify any findings. To do this, we use the ABCDE approach. Broadly, this corresponds to airway, including inspection of the trachea, carina, bronchi, and hilar structures; breathing, including inspection of the lungs and pleura; cardiac, including inspection of the heart size and borders; diaphragm, including inspection of the hemidiaphragm and costophrenic angles; and finally, everything else, which includes inspection of the mediastinal contours, bones, soft tissues, tubes, valves, pacemakers, and having a final check of important areas to review. Remember, when interpreting an X-ray, the images are laterally inverted. Let's now look at each area in more depth. The first area for inspection is the airway. When assessing the airway, the following structures should be examined: the trachea, carina and bronchi, and hilar structures. The first thing to consider when inspecting the trachea is whether there are any signs of deviation. Broadly, this can be broken down into true deviation and apparent deviation. True deviation, that is deviation caused by pathology, can be the result of a large pleural effusion, a tension pneumothorax, and lobar collapse. In the case of a large pleural effusion and tension pneumothorax, the trachea will deviate away from the site of pathology. In contrast, with lobar collapse, the trachea will be pulled towards the side of the collapse. In any case, tracheal deviation suggests serious underlying pathology and should be immediately escalated. Apparent deviation is much less concerning, as this is usually due to the rotation of the patient. To confirm this, refer back to the right mnemonic to assess whether the medial aspect of the clavicles are equidistant from the spinous processes. It's also worth noting that the trachea is normally located to the right of the aorta, and so what may appear as a very mild deviation to the right is actually normal. In this film, we can see a large pleural effusion in the left middle zone and lower zone. As a result of this, the trachea, which should be central, appears deviated to the right, away from the effusion. The carina refers to the division of the trachea into the right and left main bronchus. The right and left bronchi supply air to the lungs, entering at the right and left hilum. The right main bronchus is wider and more vertical than the left. Because of this, it's often the site of an inhaled foreign body, and should always be considered in paediatric patients presenting with signs of acute respiratory distress. The hilar of the lungs contain the pulmonary vessels and major bronchi, pulmonary ligament, and the lymph nodes, which are normally not visible. They are normally of a similar size and symmetry, and therefore asymmetry can be suggestive of pathology. When assessing for enlargement, it's important to note whether this is unilateral or bilateral. Symmetrical bilateral enlargement is often indicative of sarcoidosis, and in these cases, a lymph node biopsy will often be needed to confirm a diagnosis. In this image here, we can see that both the left and right lung hilum appear enlarged. In these cases, a lymph node biopsy will often be needed to confirm a diagnosis. Unilateral or asymmetrical enlargement should always raise the suspicion of malignancy and will usually require further investigations, such as a bronchoscopy and tissue biopsy to assist with the diagnosis. Here we can see a PA film with the left and right hilum highlighted. The left hilum is often up to 2 cm higher than the right. This is a normal variant. Moving on to assessing the breathing, the following should be examined: the lungs and the pleura. When inspecting the lungs, it's important to divide these up into 3 zones, inspecting closely for any abnormalities and asymmetry. As shown in this film, we can divide the zones up into the upper zone, middle zone, and lower zone. There are many abnormalities that may be found within the lungs. Symmetrical changes in the lungs are often seen in pulmonary edema. Increased shadowing within the lung fields may be indicative of consolidative changes or malignancies. And finally, the complete absence of lung markings with possible tracheal deviation may be indicative of a pneumothorax. In pulmonary edema, there are some common signs that you may see on film. This includes airspace opacification, classically in a batwing distribution, curly B lines, pleural effusions, which may cause costophrenic angle blunting, and fluid in the interlobular fissures. Looking more closely at the previously mentioned pathologies, the first film shows pulmonary edema. Whilst all features aren't apparent, there is widespread airspace opacification, resulting in a hazy appearance of the lung fields, with fluid visible in the interlobular fissures. Common causes of pulmonary edema include left heart failure, mitral regurgitation, and fluid overload. Consolidation is a term used to describe the replacement of air in the alveoli by materials such as pus and blood. In this image, there is clear consolidation of the right upper lobe, bordered inferiorly by the horizontal fissure. One of the most common causes of this is pneumonia. However, malignancy can also cause this presentation, and so further investigations must be undertaken. In this film, there is an area of rounded consolidation in the left lobe with a clear border. In this example, this is likely to indicate an underlying malignancy. When considering a diagnosis of a pneumothorax, it's important to consider whether it has a primary or secondary cause. The term primary pneumothorax is used when the patient has no history of respiratory disease, such as seen in the left image. Here, the right lung appears to have completely collapsed, resulting in a dark right lung field. When the patient has a known respiratory condition, such as COPD, that may have contributed to the collapse of the lung, this is termed a secondary pneumothorax. Sometimes, the collapse of the lung can lead to a deviation of the trachea, which is pushed away from the side of the collapsed lung. This can be seen in the right image, where the collapse of the left lung has resulted in the trachea being pushed to the right. Notice again the surrounding darkened lung fields as a result of the lung collapse. When this happens, this is termed a tension pneumothorax, which requires immediate emergency decompression with a large bore cannula. This should be inserted into the second intercostal space in the mid-clavicular line. The pleura refers to the membrane surrounding the lungs, which is not usually visible in healthy individuals, but can become visible when thickened. One of the most common causes of pleural thickening is a cancer called a mesothelioma, which is usually preceded by a history of asbestos exposure. The pleura should extend to the thoracic wall, and therefore a visible pleural line should raise the suspicion of a pneumothorax. However, it's not only air that can become trapped in the pleural space. A collection of fluid and air in the pleural space is known as a hydrothorax, and a collection of blood is known as a hemothorax. A collection of pus is called an empyema. Other findings that may be visualised when inspecting the pleura include pleural plaques, which are often mistaken for malignancies. These are normally secondary to asbestos exposure and don't usually require any treatment. Moving on to assessing the heart, the following two elements should be examined: the cardiac size and the cardiac borders. When assessing the size of the heart, a cardiac size of greater than 50% of the thoracic window is abnormal, as the cardiothoracic ratio should be less than 0.5. Remember, the cardiac size can only be accurately determined when using a PA film, due to an AP film exaggerating the size of the heart. There are many different causes of cardiomegaly, including valvular heart disease, coronary artery disease, pulmonary hypertension, and congenital heart disease. When measuring the size of the heart, a horizontal line should first be drawn between the two widest points of the heart. This measurement is then compared to a horizontal line drawn between the two widest points of the rib cage. The left picture depicts a PA film of a normal chest X-ray. The two horizontal lines represent the width of the heart and the width of the thoracic window. When these are measured, the cardiac size is less than 50% of the thoracic window, and so this is normal. The film on the right clearly shows a patient with cardiomegaly, as the heart occupies a much larger area of the thoracic window. In healthy individuals, the borders of the heart should be clearly visible and well defined. The right heart border is made up mostly by the right atrium. Loss of this border is usually due to right middle lobe consolidation, often secondary to an infection. The left heart border is made up mostly by the left ventricle, and a loss of this border is associated with lingular consolidation, which is also often secondary to an infective cause. Moving on to assessing the diaphragm, it's important to examine the following structures. Firstly, the left and right hemidiaphragm, followed by the costophrenic angles. In healthy individuals, the right hemidiaphragm often sits higher than the left due to the presence of the liver below. The stomach is found under the left hemidiaphragm, and so visualization of a gastric bubble is often possible. A key finding that cannot be missed and should be immediately escalated to a senior is a pneumoperitoneum, which refers to the accumulation of air under the diaphragm, resulting in the separation of the diaphragm from the liver. This is often secondary to a bowel perforation. Looking more closely at this finding on film, we can see here that the diaphragm appears to have peeled away from the liver, with free gas accumulating under the diaphragm. Left untreated, pneumoperitoneum carries a very poor prognosis, and therefore prompt treatment, often with an emergency laparotomy, is required. The costophrenic angles reflect the dome shape of the hemidiaphragm as it meets the lateral chest wall. In healthy patients, this is well defined with a clear angle. The loss of this angle is termed costophrenic blunting, which is often secondary to the accumulation of fluid, consolidation, or hyperinflation of the lungs, which is often seen in chronic obstructive pulmonary disease. This film is particularly useful to compare a normal costophrenic angle to a blunted one. On the right, although consolidation can be seen in the right upper lobe, there is a clearly defined right costophrenic angle. Comparing this to the left, the costophrenic angle is completely obscured, possibly due to a left lower lobe pneumonia. There is also a loss of the left cardiac border. Finally, it's important to examine everything else, which focuses on reviewing the mediastinal contours, including the aortic knuckle and aortopulmonary window, the bones and soft tissues, tubes, valves and pacemakers, and final review areas. Let's focus first on examining the mediastinal contours. The two structures here that need to be scrutinised include the aortic knuckle and the aortopulmonary window. The aortic knuckle refers to the lateral edge of the distal aortic arch, which curves to form the descending thoracic aorta. A loss of this may suggest an aortic aneurysm. The aortopulmonary window refers to the space between the aortic knuckle and the pulmonary vessels within the lung hilum. This can be lost in mediastinal lymphadenopathy, which is often secondary to malignancy. Moving on to assessing the bones and soft tissues, you should inspect the bones, including the ribs and clavicles, for any visible fractures, lytic or sclerotic lesions. The presence of these may be suggestive of bony metastases. The soft tissues should also be inspected for any abnormalities, such as a hematoma, being mindful of normal variants, such as breast asymmetry. There are many pieces of medical equipment you may see on a chest X-ray. Some of the most common pieces seen in exams include nasogastric tubes, central lines, ECG leads, artificial heart valves, and pacemakers. In this film, you can clearly see ECG leads that have been clipped onto the patient. In this film, you can see a pacemaker on the right-hand side. This is usually placed under the skin and will often be connected to 1, 2, or 3 leads corresponding to an atrial and/or ventricular electrode. In this film, we can see a correctly placed nasogastric tube. For further information on assessing the placement, check out our Geeky Medics article. There are a few final areas to check to avoid missing any pathology. These include the lung apices, the retrocardiac region, behind the diaphragm, and finally the lung peripheries. The last thing you need to do after you've interpreted the chest X-ray is to document your findings. To do this, you'll need to ensure you include the patient's details, the date and time the chest X-ray was performed, the indication and clinical context necessitating the X-ray, the findings from the X-ray, your overall impression, your plan for managing the patient, and finally, your name, grade, signature, professional registration number, and contact or bleep number. Now we've worked through our ATE approach for interpreting chest X-rays, it's time to put our skills to the test and work through some case studies. Our first case study concerns a 71-year-old patient who has presented to A&E. They are feeling feverish and complaining of a new productive cough. Pause this video to have a go at working through this X-ray before the answers are revealed. Starting with rotation, the clavicles are difficult to visualise, making it challenging to identify any rotation. Moving on to inspiration, there are 5 to 6 anterior ribs that can be visualised, alongside the lung apices and costophrenic angles. Looking at the projection, the scapula do not appear visible, and so this is likely to be a PA projection. Finally, the left hemidiaphragm is visible to the spine, and the vertebrae are visible behind the heart, suggesting adequate exposure. Moving on to assessing the airway, the trachea is visible and does not appear to be deviated. The carina and bronchi appear normal, as does the right lung hilum. The left hilum is difficult to visualise. Looking at the lungs, there is ill-defined opacification bilaterally, particularly in both the right and left, middle and upper zones. The pleura appear unremarkable. Looking at the heart, the contour of the heart is clearly visible and the heart size appears slightly enlarged, occupying greater than 50% of the cardiothoracic window. The hemidiaphragm are clearly visible with no costophrenic blunting. And finally, there doesn't appear to be any bony fractures, soft tissue injuries, or any medical paraphernalia. Putting the symptoms together of feeling feverish with a new productive cough, it's likely that this patient is suffering from pneumonia and should be managed according to the CURB 65 score. Moving on to our next case study, an 18-year-old presents to A&E with shortness of breath after a severe motorcycle accident. The medial aspect of the clavicles are equidistant from the spinous processes, and so there is no rotation. There are over 5 to 6 anterior ribs visible, so inspiration is adequate. This is a PA projection as there are no visible scapula and heart size appears normal. The hemidiaphragm are clearly visible, and the vertebrae visible behind the heart, indicating adequate exposure. Assessing the airway, the trachea is visible but deviated towards the right-hand side with mediastinal shift. The carina is difficult to appreciate due to the displaced trachea, but the bronchi are clearly visible. Looking at the lungs, on the right there are visible lung markings, but loss of volume due to mediastinal shift. On the left, there is an absence of lung markings, indicating a pneumothorax or a collapsed lung. The collapsed lung, in conjunction with the mediastinal shift, indicates the presence of a tension pneumothorax. The cardiac size is normal, although shifted to the right. The left heart border is less defined, which likely reflects compression from the adjacent lung parenchyma. The right hemidiaphragm is normal. The left hemidiaphragm is also normal, although there is slight distortion of the pleural spaces. Looking at the bones and soft tissues, there are no gross abnormalities visible. Metallic stickers appear to be visible, which are likely used for the attachment of ECG leads. Putting the symptoms together with the findings of a collapsed left lung with tracheal deviation, it's likely this patient has a tension pneumothorax, secondary to trauma. It's worth noting that in patients with clinical signs and a history in keeping with a tension pneumothorax, treatment should never be delayed in order to obtain X-ray imaging. Clinical signs include tracheal deviation, distended neck veins, shortness of breath, and absent breath sounds over the affected lung. In these cases, the diagnosis should be made clinically, and urgent needle decompression should be performed by a senior clinician. Well done, you've made it to the end of this video tutorial. Hopefully you now feel more confident interpreting chest X-rays using a structured approach. For further information on chest X-ray interpretation, check out our guide on the Geeky Medics website. You can also practice interpreting X-rays using our OSCE station scenarios.